Good afternoon and hello everyone. Welcome to session 2 of Intensifying Treatment to Achieve Blood Pressure Control, sponsored by the National Association of Community Health Centers. My name is Elizabeth Breidenbach. I'm a meeting and event specialist based in the Clinical Affairs Division here at NAC, and I'm pleased to bring you this event with my division colleagues from the Million Hearts team. Before we get started, I would like to review a few housekeeping announcements. You have physically joined this online event by either calling in or using computer audio. All attendee lines have been muted and will be muted for the duration of this event. The duration of this live event is approximately 45 minutes, including introductions, presentations, and Q&A. Thank you for all of the questions that you have submitted in advance. Our panelists do have that, and they're ready to answer those later on during today's session. But if you do have any additional questions, the Q&A box is located in the lower right-hand side of your computer screen. Simply type your question into the box at any time and make sure that you submit by hitting either the enter button on your keyboard or clicking that so we receive your questions. Friendly reminders, today's event is being recorded and all attendee lines have been muted. This event will be posted online for a post-event review at your leisure. At this moment, I'm going to turn things over to Judy, who will be introducing us and getting us kicked off. Judy, the floor is yours.
Thank you so much, and welcome to the second Million Hearts Learning Lab. I'm Judy Hannon, the Senior Advisor for the Million Hearts Initiative, a national initiative designed to prevent 1 million heart attacks and strokes and other cardiovascular events in a 5-year period. Improving hypertension control is the major driver about whether we hit the million events or not. And you're going to learn today that intensifying treatment is one of the best ways to improve hypertension control. We are excited that so many of you are joining us today, and we are counting on your efforts to help us achieve our goal. The learning objectives for today include reviewing recommendations and evidence supporting the use of multiple medication classes for controlling blood pressure, identifying barriers to using multiple medication classes to treat patients with hypertension, and discuss how to integrate the use of multiple medication classes into treatment for patients with hypertension, including the use of single pill combination medications. We have 2 first-rate faculty here today from the American Medical Association to answer the many excellent questions submitted in advance and those that you're going to pose here today in the Q&A. At this time, I'll turn it over to Meg Metter from NAC to introduce them. Meg?
Thank you, Judy. Next slide, Liz. So first, I just want to say that thank you for being here today. We're very excited about this session. It's the second of 5 that we have planned using this mixed methods format. So we had some pre-work, an audio recording that will ensure that you have access to. We'll send that link out again because it's so great. We had a survey that allowed you to send your questions in advance. And then, of course, today's live events. The total time is 60 minutes for all 3 of those activities, and that will allow those who are clinicians on the call to earn 1 CME credit. And we will be sharing out that information at the end of this recording and then sending it out by email to those in attendance today. Next slide. Just quickly want to introduce, as Judy said, we have 2 excellent faculty from the American Medical Association with us today. The first is Dr. Mike Raycott. He's the Vice President of Health Outcomes. Next slide. And joining him is Dr. Neha Sachdev, who is the Director of Health Systems Relationships. So without further ado, I'm going to turn it over to them so that we can get started.
Thanks so much, Meg, and thanks everyone for joining us today. We are going to briefly review about 15 minutes of slides here and then get to the Q&A. Hopefully you enjoyed the pre-work and listening to the audio recording. Next slide, please. So looking at the responses from the pre-work shown here, it looks like about 1 in 5 prescribers who responded use single pill combinations at least half the time, and a little more than 1 in 3 said that they prescribe single pill combinations 10 to 25% of the time. I'm going to briefly review some of the reasons why using combination therapy benefits patients and try to motivate more of you to consider prescribing single pill combinations more frequently. Next slide. So listed here are 4 common barriers to prescribing combination therapy: cost, availability, side effects, and patient concerns. Each of these is very important, and Dr. Sachdev will be addressing them in a few minutes. I'm going to focus on the importance of treatment intensification and the management of hypertension, the benefits of using combination therapy, initiating treatment using combination therapy, and finally, the benefits of single pill combination therapy. Next slide. So I'm sure some of you are very familiar with this, and I did review it in the pre-work, but these are 3 key processes to improving blood pressure control, and they include adherence to treatment, frequency of visits for people with uncontrolled hypertension, and treatment intensification. We know from data in the real world and clinical trials that adherence to antihypertensive medication 1 year after starting the medication is about 57%, that the average time between visits for someone with uncontrolled hypertension is about 14 weeks, and that the probability of intensifying treatment for uncontrolled patient is about 13% or occurs during 1 in 7 visits. So researchers at Columbia University wanted to know which of these 3 processes would have the biggest potential to improve blood pressure control. So they created and then validated a simulation model to see what would happen if each of these processes was independently performed perfectly, and then they looked at the impact on blood pressure control. So if adherence to antihypertensive medication treatment at 1 year improved to 100%, so perfect, from 57% where it currently is, blood pressure control would improve from 46% to 57%. And independently, if visit frequency was increased to every week, which was considered perfect, from the current every 14 weeks, blood pressure control would improve from 46% to 68%. But what's really, I think, important here is that the probability of intensifying treatment, if performed what was considered perfectly here, occurred on 2 out of every 3 visits instead of 1 out of every 7 visits. Blood pressure control would improve from 46% to 80%, more than any other process here, and would by itself achieve the million hearts goal of getting to greater than 80% control. So this clearly illustrates the impact that treatment intensification can have on blood pressure control. Next slide. So we also know that most people with hypertension are going to require 2 or more medications to reach blood pressure goal. For those who are uncontrolled on a single medication, there are really only a few options. You can either increase the dose of an existing medication, change to a different single medication, or add an additional medication from a different class. Now, adding a new medication class, even at low dose, is 2 to 3 times more effective on average than increasing the dose of an existing medication. And when you add a new medication at low dose, you'll typically see on average about a 7 millimeter drop in systolic blood pressure. And if you add a medication at a standard dose, you'll typically see about on average a 9 millimeter drop in blood pressure. And if you add a medication at maximum dose, you would see a drop of systolic blood pressure of about 11 millimeters of mercury on average. So what's important to know, to understand here, is that increasing the dose of an existing medication is only going to result in 2 millimeters approximately of blood pressure lowering for systolic blood pressure, much less than the 7, 9, or 11 millimeter reduction you can expect if you add a new medication class, as I described. So on the next slide, really, this is the take-home message for intensifying treatment. When intensifying treatment for high blood pressure, adding a new medication class is more effective, much more effective at reducing blood pressure than increasing the dose of an existing medication. Next slide. So now I want to talk a little bit about strategies to use when initiating treatment for hypertension. The 2017 ACC/AHA Clinical Practice Guideline has a recommendation shown here for initiating drug therapy with 2 agents from different classes if blood pressure is greater than 140, greater than or equal to 140 over 90, and approximately 20 millimeters systolic or 10 diastolic above treatment target. So for most people, that would mean use 2 medications if blood pressure is 150 over 90 or higher. And I'm sure that many of you are likely familiar with this recommendation, which is an expert opinion. Next slide. This recommendation may be less familiar, but it has even stronger evidence. It's a grade 1B evidence from randomized controlled trials. And it says that for adults with a blood pressure of 140 over 90 or higher, treat with a combination of non-pharmacological and drug therapy using 2 antihypertensive medications from different classes, and then reassess blood pressure in 1 month. So again, strong evidence to support using combination therapy when initiating drug therapy for hypertension. Next slide. So to briefly summarize the benefits of initiating treatment with combination therapy using 2 medications from different classes. Compared to initiating treatment with a single drug therapy, combination therapy lowers blood pressure more and more quickly. It'll likely reduce the frequency of adverse events when lower dose combinations are used compared to higher dose single drug therapy, and increases the likelihood that the patient will be on combination therapy years later, which is because a majority of patients started on monotherapy or single drug therapy will remain on single drug therapy over time. This has been studied for up to 3 years. And those that initiate on combination therapy tend to remain on combination therapy. It's very well tolerated over time. So I think that's a really important point to consider when you're initiating treatment. Next slide. So the recommendation to initiate treatment using combination therapy is even more clearly illustrated in the 2018 European Guideline for Hypertension, where the recommendation here is to initiate drug treatment using single pill combination therapy for most patients with a level of evidence of grade 1A, which is the strongest level of evidence. Next slide. Similar to the benefits mentioned earlier for using combination therapy, the benefits of initiating treatment using single pill combination therapy are that single pill combination therapy helps patients reach blood pressure goal faster, may reduce adverse effects compared to high dose monotherapy if lower doses are used. It may improve adherence to treatment, extremely important. And I think probably the most important is that initiating therapy with single pill combination compared to monotherapy has been shown to improve outcomes like lowering the risk of heart failure, stroke, coronary heart disease, and even death. So these are some very compelling reasons to consider initiating treatment with single pill combinations whenever possible. Next slide. So that's a very quick and brief review of some of the benefits of using combination therapy and single pill combination therapy. Now I'm going to hand it off to Dr. Sechdev, who will review some of the barriers to prescribing combination therapy and offer a few strategies to use to try to overcome those barriers. Dr. Sechdev?
Thanks, Dr. Raycatz. So I'd like to go through each of these barriers one by one, and I'll say these are barriers that we, hear frequently in our work with organizations and care teams, but also that we're coming through in some of the pre-work responses. So if you could just go on to the next slide, I'd like to start with cost. This is a very real concern for many, many patients and providers. And I think it's definitely worth addressing. So a couple things to just keep in mind are that many single pill combinations are available as generic options, and many are also available on formularies. And we'll talk more about that in a minute. For patients who do not have insurance coverage, discount pharmacy programs are also available, and single pill combinations may be available through those. So for example, $4 lists or coupon apps. Next slide. And I wanted to show this table from our AMA a sample table here. It's from our AMA medication treatment protocol. And just to point out that there are these generic options and a little bit more details about some estimated cost. So if you look at the second column, you can see that a lot of the medications that are available as combinations, there are some generic options listed here. And then the column that's all the way on the right gives an estimated cost of a 30-day supply of medications for patients who do not have insurance coverage. And you can see that many of these medications are available for less than $10 a month or less than $20 a month. So it is feasible for patients to be on single pill combinations and 3 classes of medications for less than $20 or $30 a month. Now, of course, for some patients that might still be too much, but I just wanted to share this because in some cases, this may be less than is expected. And for some patients, it may be similar to the cost of their current regimen. Next slide, please. Okay, so moving on to availability, and this is related to cost. I mentioned that single pill combinations can be available on formularies. And we found that, across the country, there are combinations that can be covered, including being on Medicaid and 340B formularies, and that these medications are oftentimes first line or preferred, so they do not need prior authorization. What can be helpful is to look at your patient population and just see what's available to them. We've seen organizations compile this information and share it with providers and care teams, and that can just be very helpful, as many people may just not be aware of what actually is already available. Next slide. So talking a little bit about side effects, Dr. Rakotz already mentioned, using lower doses and the benefits of using lower doses can have, one of the benefits is that you can have reduced side effects. The other thing I just want to point out is that many of the medication classes that are being used in single pill combinations are the same medication classes that you're using already potentially as monotherapy. So for example, if you're prescribing a combination of an ACE and a calcium channel blocker, these are two medications that are very frequently prescribed individually as monotherapy. Next slide, please. I also wanted to share this article, which was a systematic review and analysis of over 30 studies. And the authors concluded that when they looked at initiating treatment with low to standard dose combination therapy compared to standard dose monotherapy, the combination therapy was more efficacious at lowering BP and did not lead to, without a significant difference in medication withdrawals. So this just points to the tolerability of using combination therapy again. Next slide. All right, and patient concerns. And I actually love that this gets raised as a barrier or a question, because we should be thinking about our patients' thoughts and perspectives. So a couple things here are that the benefits of single pill combinations here are really strong, right? If you're using one pill that has two medication classes, for the patient, the pill burden is the same, but you are getting, as Dr. Rakotz covered, a much better BP lowering effect. The other thing to think about is that having one medication instead of two can help with adherence. This means less refills for patients, less medications to manage. So it's just great to think about that as well. And if you're initiating with a single pill combination, that can be very helpful. All right, next slide, please. All right, the last thing I just wanted to touch on before we move into our Q&A is implementing a treatment protocol. And I'll say this again, I know I've said this a lot, I'll say it again, and it is that a treatment protocol does not replace clinical judgment. It's not meant to supersede any individualized treatment decisions, but it can be really helpful to guide evidence-based treatment intensification. So if you're thinking about implementing a protocol, just wanted to outline a couple key considerations from our experience. And I frame these as a process, but really all of these are working together to help create and implement a protocol that's useful for your care teams. First, the development process is so essential. Making sure that you've got a protocol that's easy to use and understand. If a protocol is really complicated or very long, takes too long to figure out what to do, it probably won't get much use, especially if you're hoping that it'll get used at the point of care. People are so busy, it's got to be easy to use and understand. The other thing is customizing it to make sure it's appropriate, for your patients and for your organization. So I mentioned how you could look at what's available on your formularies, and this is something that organizations we've worked with have done. So they've incorporated it into their protocol or provided that information in a way that's complementary to their protocol. And then essential is to get your end user input. So getting providers involved from the very beginning and prescribers, people who are able to tell you, how much it should be customized or if it is actually a protocol that is easy to use at the point of care. Then if you're thinking about the promotion, you could have the best protocol in the world, but if nobody's using it, it's also not very helpful, or if nobody knows it exists. So when you're thinking about how to make sure everyone's aware, encouraging care team members to also know where the protocol is, and making sure that it lives somewhere that's easy to access. So is it going to be something that's printed? Is it something that's embedded in your EHR? Again, if it's hard to find and it's buried, it's probably not going to be used as much as you'd like. And then provider education. So making sure providers really understand the rationale and the protocol. And if you've got provider input from the development, then it's really helpful in terms of getting education from their peers. And then adoption and utilization, again, if everyone knows it, uses it for a little, but then forgets about it, or it's something that just gets left alone for a very long time and becomes outdated, it also may not be the most useful. So thinking about iteration and incorporating feedback as you roll it out, or just revisiting it regularly. The other thing is to think about just educating on a consistent basis. You know, there's so much going on and people are so busy that just having, keeping it top of mind can be very helpful. And if you've got new team members coming in, just making sure they're aware as well. And then the last point being data. So just seeing, you know, if you're able to see if it's being used, and if there's if you're looking at even some of your medication data, are you able to see if that supports what's in the protocol? That can also be really helpful to see how you can better drive adoption and just how much it's being used to begin with. I know there was a couple questions about some sample treatment protocols. These are available and they can be really, really helpful. So you're not starting from scratch. It gives you a place to just begin. We'll put a link out there for you so you're able to have that link, because there are sample protocols available. And the other thing I'll say is, even though this might seem like a lot, it is really feasible. And we've seen organizations go through this process and successfully implement and use a protocol. So with that, I will wrap up and open it up to my colleagues for Q&A.
Great. So thank you so much, Dr. Rakotz and Dr. Sachdev. We had some excellent questions that were submitted in advance, so I'd love to start there. One is this. I'm going to pose this to you, Dr. Rakotz, but also, you know, obviously feel free to respond to Dr. Sachdev. One concern about using single pill combinations is that if a patient has an adverse reaction, it may be more difficult to isolate which drug is causing it. Do you have any advice on how to address this when prescribing combo pills for patients?
Yeah, I think it's a great question. It's probably one of the most common questions that we get around using single pill combination therapy, and it's really good. And the answer is, you know, the truth is, it's almost impossible to know which medication that it is unless the person was on one of the medications before being converted to a combination. But if you start on initiating with a combination, you're really not going to know. But I think this I think is the really important point about that. The benefits of using single pill combination therapy that were reviewed here today, and the fact that according to the systematic review that Neha touched on, the actual discontinuation rate of single pill combos it's very uncommon to have to discontinue somebody due to adverse events, especially when used at lower or even standard dose. So it's in about the 2 to 3% range that you'd have to discontinue. And interestingly, when you look at monotherapy, it's in the same 2 to 3% range. So that's why when Dr. Sachdev said there's no significant difference, that's because you really won't see that any more commonly with a dual combination versus monotherapy. And I would say because of all the benefits that are outlined, they far outweigh the same risk of starting with a single drug. Now, knowing that if you use a single drug and there's an adverse event, you'll know which one to stop. I think that is absolutely true. But given the benefits and the low discontinuation rate for combinations being essentially the same as monotherapy, I would highly recommend using the combination therapy. And if you have to discontinue and restart one of the agents or a different agent, you do. But fortunately, you know, there's over 100 antihypertensive medications, most of which are generic and low cost. So I think that it's a good thing to try, a good strategy to use. I hope that answers the question.
Thanks, Dr. Rakotz. And I'm going to ask a follow-on question. when multiple medications are used, how do you make decisions about dosing adjustments?
Yeah, that's another really good question. And I think this is where, probably clinical experience and clinical judgment and comfort of the prescriber comes into play. I'll use the most commonly prescribed combination, which is lisinopril hydrochlorothiazide. It's by far the most commonly prescribed single pill combinations used, and it's actually in the top 10. It's number 9 on the list of most frequently prescribed antihypertensive medications, the other 9 all being single medications. So when you think about lisinopril HCT, you have multiple dosing options. You have 10 milligrams of lisinopril that you could choose from, all the way up to 40 milligrams. I'm sorry, up to 20 milligrams in the individual tablet. And for hydrochlorothiazide, you've got 12.5 or 25, and you've got those in multiple combinations. So, and the indications for the medication are to take 1 or 2 tablets daily. So your range for using this combination is anywhere from 10/12.5 all the way up to 40 over 50 milligrams per day of the medication, dosed once daily. So it's nice to have those dosing options. I think as far as which to increase really is going to be based on the patient and what you're trying to achieve. Somebody, who has an indication for a higher dose of an ACE inhibitor, that's, an easy choice to make. And the same thing for somebody who obviously has the need for a higher dose of the diuretic component in hydrochlorothiazide. Many prescribers are very familiar with hydrochlorothiazide, for example, and the literature supporting the use of it at higher doses based on clinical trial outcomes. And so they want to be able to dose it at 25 or 50 milligrams. Others are more comfortable with 12.5 and are more comfortable titrating up an ACE inhibitor, knowing that they're going to be monitoring renal function while they're doing this. So I can't give you a great answer as far as which one people should focus on. It really comes down to the individual patient and clinical judgment and prescriber comfort in titrating these medications. But the good news is most single pill combos have at least as many dosing options as I just described. Some have many, many more, twice as many options for dosages to be changed. And usually you can increase incrementally one of the individual components in 2 to 4 different ranges, let's say, typically, for both of the components. So you have a lot of options there, a big number of combinations to choose once you decide which one that would clinically benefit the patient more, or that you as a prescriber are more comfortable in using.
Thank you. That's very helpful. I'm going to switch gears a little bit, sort of back to the protocol conversation, and pose this one to Dr. Sachdev. So what are some strategies to increase provider engagement and buy-in to use a protocol?
Yeah, I think that's so important first to get that provider buy-in. And I talked about this earlier, but just having providers involved throughout the implementation process can just be so helpful here. So first, if providers know that their colleagues helped create the protocol, that can be helpful. If providers are able to learn from their colleagues about the protocol, that's very helpful. It also allows for providers to have some peer-to-peer informal conversations. And as the protocol gets disseminated and used, if you hear that your colleagues are using this protocol and they're seeing improvements in their patient's BP control, that can be really impactful. And then I'll just reiterate that it's really important to have protocols that are simple and easy to use and access. Just from our experience, I can't tell you how many times we've seen protocols that are just very complicated and hard to follow, and that just doesn't make it easy for people to use at the point of care. It also, what we've also seen is that people may not realize that the protocol exists. So just making sure that it's, again, top of mind. Everybody's so busy. So just keeping it at the forefront and making it easy to find and access is also helpful.
I have one additional question. So I think you had shared earlier some really important things to keep in mind when developing a protocol and making sure that it's set up in a way that people use it and adopt it. Sort of a follow-on question to that is, how can you drive provider prescribing behavior change?
Yeah, and I'm going to say that there's no easy or short answer to that one. I mean, we've been discussing just how important it is to improve treatment intensification, and therapeutic inertia is a significant barrier to improving blood pressure control. So again, I can just offer a couple thoughts from our experience. First is that I don't think one thing by itself is going to make a difference on its own. So there are many reasons for therapeutic inertia, and overcoming it may require, multiple tactics and strategies. The other thing I'll say is that provider education is, absolutely necessary. It's foundational. Providers, making sure they know they have the knowledge and the evidence is great. But by itself, it may not be enough for somebody to change what they've been doing for, 10 or 20 years. The other thing I'll say, though, that can be very motivating is data, especially if it's personalized to someone. So if you're seeing a list of your own patients who are uncontrolled and you haven't had and who have not had an intensification, can be really helpful just to see that for providers and just highlight the opportunity to improve. Can also provide a place to start taking action. Mike, is there anything you would add there? And I'll just go ahead and say it's totally okay to call us Mike and Neha.
Yeah, I don't have anything additionally to add there, but I think I would like to try to answer one of the questions that came up in the chat, if that's okay, Meg, in the quick Q&A.
Absolutely, thank you.
Yeah, so there's a question that came up that says, how do you address and manage patient concerns over sexual dysfunction side effects? And this is, I wanted to address this because it's so common and it's not often talked about, or at least I don't think it's often talked about enough. So, I can speak from my own personal experience and my experience working and training and collaborating with physicians across the United States. And I think these are common findings that especially men concerned about erectile dysfunction are really concerned about taking antihypertensive medication, because regardless of whether the medication they're taking or not contributes to erectile dysfunction, they really worry about that and often skip doses on weekends or even don't take the medication because of that concern. And I think the important message to get across to patients and have a really good shared decision on this is that when people start to have erectile dysfunction, the most common cause that's a pathologic cause is typically from vascular damage that's occurring. And that's most often occurring because of uncontrolled high blood pressure. And that deteriorates erectile dysfunction over time and is a more significant contributor to that concern of sexual dysfunction than adverse effects from an antihypertensive medication, which actually preserves sexual function over time. And so the thing that many fear in causing erectile dysfunction actually helps prevent it and preserve function over time. So I think this is something that, again, it's not often talked about. It's not talked about enough, but it is a major driver in many people for not wanting to adhere to taking their antihypertensive medication as prescribed. So thanks for asking the question. I think it's an important one.
Thanks, Mike. I appreciate it. And I like calling you Mike and Neha because I have to say NAC has worked and collaborated with these two amazing clinicians for a number of years. And so they feel like family to me. I do want to just point out a quick couple housekeeping items. One, yes, we will be sharing the slide deck out. We will also be posting the recording, and we'll provide that information to all of the attendees. And there is a great link in the Q&A, and you can copy and paste that link to make it active for the AMA's hypertension treatment protocol. So I encourage you, if you don't have one, that is an excellent example. We can also send that out with our follow-up materials. I do want to ask a couple more questions. There's so many good ones, and it's hard to choose. So this is a question I'm going to pose to you, Neha, because there's a similar one that's in the Q&A. So the question is, how can care team members support treatment intensification? And then if you see the Q&A, there's a corollary about standing orders.
Yeah, and that's a really important point, because intensification and being able to improve intensification will definitely benefit from team-based support and team-based approaches. So again, a couple thoughts from our experience. One is that pharmacists can be very amazing partners for everyone in throughout this process. So first, just making a treatment protocol that can be really helpful, or engaging pharmacists in even just helping manage patients with uncontrolled high BP. We've seen that happen in some organizations, and it's been great. The other thing is that we didn't talk about too much today is that frequent follow-up for patients who are uncontrolled is another strategy to improve therapeutic inertia or reduce therapeutic inertia. So for patients who do have uncontrolled high BP, following up every 2 to 4 weeks and making sure that the medication changes that are made are, you're following up on those, seeing how they're changing that person's blood pressure and continuing to adjust medications if needed. That's important as well. And that's where I think care team members can be really helpful in encouraging that follow-up, helping get that follow-up to occur. And then for others who maybe have uncontrolled high BP and would benefit from treatment intensifications, doing outreach to them and getting them to come back into care can be another great way that other team members can support treatment intensification. And I also mentioned just having that protocol in a place that everybody can see it and use it is another way that I think team members can support this.
Thank you. Appreciate that, Neha. So we all know that clinicians are very busy. They have 15 or 20 minutes to often see a patient, and the EHR is hugely important in terms of decision support and choosing medications, drop-down lists, prioritizing things that we want to have providers prescribe. So, Mike, this is one for you. How can we influence EHR vendors to make it easier to incorporate and update decision support tools?
Yeah, again, another great question, and I wish there was an easy solution there, but there really, I can speak from my experience as a clinician working as, a clinician leader in multiple health systems, and then working at a medical association. And one of the main answers I think to this question is EHR vendors look to their customers for recommendations on what they should be doing and changing. And so, as somebody who now works at the American Medical Association, we have great relationships with multiple EHR vendors, but they're really looking, they're not just looking at necessarily people who teach this or people who are experts in this field, as much as they're looking to their customers for what do the customers want. So the first thing I'd say is make sure that you continually express your desire for new and updated tools and resources and clinical decision support for improving your EHR. Go directly to the EHR vendor or the contact that you have with your EHR vendor to try to push those things, because they really do listen. It doesn't mean that they'll happen quickly, but that will likely be the fastest way to do that. And then, of course, collaborating together, working with associations who are working together to make these changes, at HIMSS and again, at the American Heart Association, the American Medical Association, working towards some of these things can really help. I'll also say that I think one of the key things that the question asks is how to make it easier, because there's quite a bit of capability and function in existing EHR systems to do this, but it's not easy. So for example, and this has been well studied, pre-populating orders that are about to be placed in preference lists with medications from a treatment protocol, for example, increases the likelihood that those medications will be used. So I think that's those kinds of things are really important to think about, and they really work. So while it may not be easy, depending on the organizational processes at your healthcare organization, working with IT and the EHR vendor, some things you can do in-house, and those are really little things that can go a long way. Creating best practice advisories and complex IT workflows can be extremely challenging. But I think that's the best advice I could give, is really try to work as closely as you can with the HR vendor directly to make the suggestions, and then work locally to do some very basic things that can really help.
Thanks, Mike. And I'll say, from the National Association of Community Health Centers perspective, health center controlled networks are a great sort of economy of scale organization that can put some of this pressure on the companies to make these changes. I do have a couple more questions, and I think we have enough time for those. One is about the use of single pill combination therapy as a first-line treatment. Does it improve blood pressure control in patient populations of all races and ethnicities?
Yeah, I could take that one, Meg. I think that's that's a really important question. It's a very good question. And, when I was preparing for this and I go into the literature, when I review clinical guidelines, I look at all the studies and all the evidence quoted, and sometimes there's literally dozens of studies. And in this case, looking at the guideline recommendations for the use of combination therapy and single pill combination therapy, when you look into the studies, you're going to find many things, a mixed bag of things here on this issue. So some of the studies will actually have no data on race and ethnicity, which I don't, it is unfortunate, but some of the evidence, it just wasn't something that was studied at the time. For most, I think for many of the studies to find white and Black and Hispanic, those are often listed. And I think what I noticed in a lot of the studies was subpopulations being broken out from race and ethnicity standpoint into white, Black, Hispanic, and other. So, it's really hard to answer that question. What I can tell you is in the evidence in the clinical trials where where multiple race and ethnicities are listed, it does appear to have similar benefit across those racial ethnic groups. And when they're not broken out, but they're listed as participating, we only have the average effect. It's a little harder to determine, but I haven't seen evidence against that. But if you said specifically let's just say, for example, people of Southeast Asian descent, specifically, I haven't seen specifically in clinical trials where that was specifically looked at as a race ethnicity group that was brought out. So I think it's a really important question. Again, I've never seen anything to the contrary, that this strategy wouldn't work in all those that it's been studied in. And I think in large population cohorts that have been looked at where the race ethnicity is not always listed, and this is in Europe and in most of the countries in the world that have published literature on this, which represent most of the areas of the world, the literature is very similar. But I think it's a really good point, and it's really important to do your diligence there and look into the studies to see what was studied, who was studied, how it was studied. And I think we're going to see more and more of this as we move forward in clinical trials.
Thanks, Mike. I want to quickly point out, Allison Goldstein, thank you so much for posting another set of resources on protocols in the Q&A, so please take a look there. And then a final question for either of you before we wrap and talk about CME and upcoming events. Do you have any updates on the development of new triple combination pills?
I actually do have an update. There are two medications that are triple drug combinations that are currently in phase 3 clinical trials in the United States with FDA. They are combinations of an angiotensin receptor blocker, amlodipine, and indapamide. So it's telmisartan, amlodipine, and indapamide, starting at quarter dose, very low dose. So 10 of telmisartan, 1.25 of amlodipine, and 0.625 of indapamide. And those two drugs are broken out. There are several increases in dose for each of those in one medication all the way up to standard dose. And then in the other medication, it's the same 3 drugs being looked at, but at higher dose. So it's standard and high dose. And those are being studied. So I can't say anything about whether or not they will be cleared through FDA. I'm guessing that, hoping that they will. It looks like they will. It looks like it's going to be at least another 12 to 18 months. But I think this would be a really important combination. These classes that have been studied together can get most people to goal with the first prescription, which is great. And with one up titration, a vast majority of people. So I think that these kinds of drugs, another study, has come out recently with 4 drugs at quarter dose that was recently published in The Lancet. The Quartet study. So these drugs are coming. This one specifically, telmisartan, amlodipine, and indapamide in the United States. And there was a question in the chat about more combos with chlorthalidone. And while I don't know that chlorthalidone is coming, indapamide is a longer acting thiazide-like diuretic, very similar, but with good outcomes to support its use. And I think this will be a very important drug if the cost is not high. The people who are manufacturing this medication are working on trying to keep the cost down, which is going to be critical for it to get used. So that's the only update I have.
Really excellent. So we are almost at time. I want to thank Dr. Mike Raycotts and Dr. NACHC from the AMA. Just really informative and helpful information. I think we all need to stay tuned because it sounds like there are good things on the horizon.